All right, guys, welcome back to Underground Science. In this video, we'll be talking about thrombotic thrombocytopenic purpura, all right, also called TTP. Okay, so before we get started, this is a type of MAHA, all right? So MAHA stands for microangiopathic hemolytic anemia, okay? So if you just break apart the word, right? Microangiopathic, small blood vessels, right? Hemolytic, you you lyse red blood cells. Anemia, due to lysing of their red blood cells, you get anemia. Okay, so let's go and see how this works. So what happens here is usually either it's genetic, right, and you don't have functional Adam TS13, or you acquire antibodies against Adam TS13, okay, autoantibodies. Now, what is Adam TS13? Adam TS13 is a protein that usually degrades multimers of one Willebrand factor. So if we draw atom TS13 like this, right, it usually degrades multimers of von Willebrand factor. So let's say we have one von Willebrand factor like this, right, and it's multimers. So it's many large multimers of one von Willebrand factor, right, are present, but atom TS13 degrades these, right, into individual pieces, right, in this case, individual monomers of von Willebrand factor. But if you have autoantibodies against atom TS13, then this atom TS13 protein can no longer work properly, and you can't degrade these large multimers of von Willebrand factor, right? So you retain large multimers of von Willebrand factor, right? You retain large multimers of von Willebrand factor because you don't have functional Adam TS13 due to autoantibodies against Adam TS13, right? So you can't degrade large multimers of von Willebrand factor, leading to the presence of large multimers of von Willebrand factor, which means you're going to get more formation of thrombi, right? Microthrombi. So this increases the formation of microthrombi. Because remember, what does von Willebrand factor do? It binds subendothelial collagen, right? If this is our von Willebrand factor, it binds subendothelial collagen and induces platelet adhesion, right? Our platelets bind to von Willebrand factor via glycoprotein 1b. So if you have multimers of von Willebrand factor, right? You have a lot of von Willebrand factor, right, multimers of it, then of course we can expect that there's going to be a lot of platelet adhesion and a lot of microthrombi formation. So that's what we have here. We have low atom TS13 proteins, right, due to autoantibodies against it, leads to large von Willebrand multimers, right, von Willebrand factor multimers, and that increases microthrombus formation. So you form a lot of small clots in small blood vessels, right? So again, the main cause is autoantibodies against Adam TS13. So let's see why increased microthrombi are bad. So what do we find, right, in this disease? In TTP, you find a classic pentad. Okay, so there's 5 things we should remember. First being MAHA, right, like we said in the beginning of the video. TTP is a type of microangiopathic hemolytic anemia. Why? Why do you get hemolytic anemia? Well, if you take your small blood vessels, right? You have many small blood vessels. Let's just take many of them, right? Let's say these are all small blood vessels. Let's say supplying your kidneys or your brain, for example, right? And I have a bunch of microthrombi here because I have large multimers of von Willebrand factor because I don't have Adam TS13 to degrade it. So I have all these microthrombi, right? Basically small clots forming in these small blood vessels, right? So let's say these are all small clots. Now, what happens is because you form all these microthrombi, when red blood cells go past, right, these microthrombi, they get sheared and they get sheared and turn into cystocytes. Okay. So again, red blood cells are going by, right? and they get sheared and they turn into schistocytes, which are, if you do a peripheral blood smear, you'll see helmet cells, right? So again, red blood cells encounter these microthrombi, get sheared, and turn into schistocytes. Okay, schistocytes. All right. So that's why if red blood cells are getting sheared like that, right? That's why it's called microangiopathic, because you have this is occurring in your small blood vessels, hemolytic, because you're lysing red blood cells, right? You're shearing it, anemia, right? So if you're shearing red blood cells, you have less functional red blood cells, which means you're more likely to get anemia, right? So you can see things like fatigue, pallor, right? Like you would see in anemia, right? Weakness, and what's present inside your red blood cells, right? Remember, there's hemoglobin inside your red blood cells. So if you shear your red blood cells, right, you release the hemoglobin out, and the hemoglobin, right, can go into your spleen, right? Your splenic macrophages can process it, and you can have, and that can lead to, if you metabolize hemoglobin, right? We know that hemoglobin is made up of heme and globin, right? And we know heme is made up of iron and protoporphyrin. If you metabolize hemoglobin in your spleen, right, we know that leads to the production of indirect or unconjugated bilirubin. And indirect bilirubin goes to your liver, gets conjugated, right, via UGT, for example, right? We'll talk about this more when we talk about biosynthesis, right? But indirect bilirubin goes to your liver, gets conjugated via UGT, right? And then once it gets conjugated, it gets water soluble. So now it's called conjugated or direct bilirubin. And then direct bilirubin can then get put into your bile, right? Via certain transporters. So that's the process of bilirubin metabolism. But if you're shearing a lot of red blood cells, you may see an increase in your indirect bilirubin levels, which can lead to jaundice, right? And of course, we'll see schistocytes on blood smear. Why? Because you're shearing your red blood cells across these microthrombi that you're forming due to increased multimers of von Willebrand factor due to decreased ADAMTS13 enzymes, right? So hopefully that finding makes sense. So you get microangiopathic hemolytic anemia. Then we just said, right, we're forming all these microthrombi, many microthrombi across many small blood vessels. Well, these microthrombi are made up of platelets. So you're consuming a lot of platelets, that means, right, to form all these microthrombi. So then it makes sense you'll see thrombocytopenia, low platelet count, because you're consuming so much into making those small microthrombi. What did we say that thrombocytopenia leads to? Skin and mucosal bleeding. Okay, so you may see things like petechiae purpura ecchymosis and mucosal bleeding like GI bleeding, hemoptysis, epistaxis, menorrhagia, things like that, right? So that should make sense too. Now we said most of these microthrombi and hemolysis is occurring in your small blood vessels supplying your kidneys and brain, and even the heart too, right? But for this, let's just remember kidneys and brain as our main findings, as our main organs. So if you're getting hemolysis, right, of red blood cells that are in blood vessels supplying your kidneys and brain, then you can expect renal dysfunction and neurological dysfunction, right? So those two are also easy to remember. If you see renal dysfunction, right, like less blood flow going to your kidneys, right, you can see renal damage, which can show as proteinuria, hematuria, and increased creatinine, right? Because your kidneys are supposed to filter out the creatinine. If it can't do that due to damage because of microthrombi formation, right, and shearing of red blood cells in the blood vessels that supply your kidneys, you won't be able to properly filter creatinine out, right? Your kidneys won't be able to, so you can see elevated creatinine. And if all of this hemolysis is occurring inside small blood vessels supplying your brain, you can see things like seizures, headache, and stroke-like symptoms, right? So those findings make sense too. And the last finding, right, is fever. So that's it. That's the classic pentad that we have to know for thrombotic thrombocytopenic purpura, right? And even excuse me, even the name gives it away too, right? Thrombotic, you're forming clots, right? Thrombocytopenic, due to the formation of those clots, you're consuming platelets, so your low platelet count, which is thrombocytopenia, and purpura, right? Skin bleeding, as you would see if you had low platelets. Okay, so hopefully that all makes sense, right? Those are the main clinical features we should be familiar with. All right, so let's try to talk about lab findings now. So if you would do a CBC, right, you would think, okay, because I'm getting a lot of hemolysis, right? There's a lot of hemoglobin leaking out, right? So we should see really, really high amounts of hemoglobin. But because you have hemolysis and hemoglobin leaking out, remember, you also have haptoglobin that was going to try to bind all the hemoglobin. Okay, so if you bind a bunch of hemoglobin, right, free hemoglobin, if the haptoglobin binds, so if let's say we have a lot of hemoglobin, right, let's represent this as hemoglobin due to hemolysis, right? Your haptoglobin, the haptoglobin protein your body produces, will also try to bind the free hemoglobin so you don't get, destruction of certain tissues because we know free hemoglobin can be toxic, right, to certain tissues. So the haptoglobin, right, will bind the free hemoglobin, and then that's the way that you'll try to contain the free hemoglobin levels, right? So you actually may see low hemoglobin levels because of all the haptoglobin binding to the hemoglobin. So again, right, we're going to have haptoglobin that's going to bind all the free hemoglobin and go to the liver, right? And the liver can clear it. And then the rest of the free hemoglobin, remember, can go to your kidneys and then you can pee it out, right? So you can see things like hemoglobinuria. Okay, and remember, a lot of hemoglobin, myoglobin, things like that, just as a quick reminder, right, isn't good for your cells of your kidneys, right? Your tubular cells. So that can also damage your tubular cells too, right? But if you do a CBC, main thing to remember, you can see low hemoglobin levels, right? So anemia. And if you're to test haptoglobin, remember, haptoglobin is being used up because it's binding to all the hemoglobin. So you're going to see low haptoglobin levels too, right? If you do a separate test for it, you'll see low haptoglobins. And of course, you're making a lot of clots, right? So you're going to see low platelets too on your CBC. Okay, so that's that. Now, if you do a peripheral blood smear, you're going to see schistocytes, right? Or also helmet cells, okay, which looks something like that. So that's important to keep in mind. Why do you see schistocytes? Because you're shearing your red blood cells across the microthrombi, okay? So because you're hemolyzing your red blood cells, you're lysing your red blood cells, you're going to see certain hemolysis markers. We know LDH is an important hemolysis marker. And because you're using up your haptoglobin, you're going to see low haptoglobin levels, indicating, okay, I'm shearing a lot of red blood cells, therefore leaking a lot of hemoglobin to my blood, and haptoglobin is binding onto that. So that's why I have low haptoglobin, right? And then some of that hemoglobin, because it's an intravascular hemolysis, some of that hemoglobin can go to your spleen and your splenic macrophages, get processed into indirect bilirubin. So you may see increased levels of indirect bilirubin, which can also present as jaundice, right? So you can see that too. All right. And just remember, you can test for antibodies and you can see ADAM TS13 inhibitors, right? Or antibodies against ADAM TS13. All right. So if you're shearing, so this is important. If you're shearing your red blood cells, you can see schistocytes, like we mentioned, right? You can see low hemoglobin, low haptoglobin, right? Remember, these are important because this will all give you clues as to what's happening. And then you can also see increased LDH, right? Because that's hemolysis marker, increased indirect bilirubin, right? Indirect bili, also called unconjugated bilirubin. And you can also see an increased reticulocyte count, okay? And why am I mentioning this is because if you're shearing a lot of red blood cells, right, you're losing red blood cells. So your bone marrow is going to try to compensate for that and make a lot of red blood cells, and you can have a higher reticulocyte count because remember, reticulocytes aren't mature red blood cells. Okay, so you can see an increased level of increased number of reticulocytes if you check your or in your blood, right? So that's that, right? And then are the coagulation factors getting affected? right? The coagulation factor is not getting affected in this. It's just the fact that you're consuming a lot of platelets to make clots and shearing your red blood cells. Coagulation factors are nowhere seen in this disease. So if you test your PT and PTT, right? Remember PT's extrinsic pathway, factors 3 and 7, PTT's intrinsic, factors 12, 11, 9, and 8. That's going to be normal, right? But if you test your bleeding time, that will be elevated. Now it's kind of weird because you're forming a lot of clots, so you would expect your bleeding time to be normal because you're able to form all these clots, but the thing is you're forming microthrombi, small clots, and all these blood vessels. You consume your platelets, and then now you don't have enough platelets, right, in order to properly form a platelet plug. So your bleeding time gets elevated because you're consuming a lot of platelets. So it's basically thrombocytopenia, right? And again, if you do a bone marrow biopsy, because you're consuming so many platelets, your bone marrow is going to try to compensate and increase the production of megakaryocytes because we know platelets are cytoplasmic fragments of your megakaryocytes, right? So that's just a compensation mechanism. All right. So that's basically TTP, right? So now we can go to the treatment. If we give corticosteroids, remember corticosteroids inhibits the immune system, so you may inhibit the autoantibody production against ADAMTS13. But the main treatment would be plasmapheresis, right? Where you take out the plasma of the patient, right? Take out the anti-ADAM TS13 antibodies and put the plasma back in, right? So you get rid of, so this can help get rid of the anti-ADAM TS13 antibodies, right? So yeah, that's basically it. That's TTP. I hope this video helped a little bit. I hope it wasn't too confusing. Thank you guys for watching. See you guys in my future videos.